Welcome to a video roundtable of the New England Journal of Medicine on accountable care organizations. I'm Tom Lee, an associate editor of the journal and network president of Partners Healthcare. In a time of incredible transition in healthcare, we're all hoping that where we're headed is a delivery system that delivers higher quality care more efficiently. Are accountable care organizations, or ACOs, the vehicle? What everyone says is the devil's in the details. To talk about that today, we've got three experts with complementary perspectives. We have Gail Wilensky, an economist and a senior fellow at Project Hope, who served in a variety of roles with relevance to this topic, including administrator of the Healthcare Financing Administration and chair of MedPAC. We have Elliott Fisher, who's the director of the Center for Health Policy Research and a professor of medicine at Dartmouth Medical School. And we have Larry Casalino, who's the chief of the Division of Outcomes and Effectiveness Research and a professor at Weill Cornell Medical College. Elliott, why don't we start with you? Because you are the person, for better and worse, who's credited with coining the phrase accountable care organizations. What are they, and what is happening right now to actually bring the concept to life?
The idea of accountable care organizations are sort of three key attributes: organized care, performance measurement, and payment reform, all aligned, if possible, to support physicians in their efforts to improve care. So the notion of organized care: let's encourage physicians and hospitals to come together to become more organized entities that are capable of managing and being responsible for the care of an entire population of patients. Second thing is performance measurement. Let's make sure that they report regularly on performance measures that will reassure the public and payers that the quality of care is actually improving. Because if you're going to change the payment incentives, you don't want to reward the stinting on care that we saw in the 1990s. So performance measurement is a second attribute. And then the third key element is getting the payment system aligned with what we want to see: better care and lower costs. So there the notion is continue under fee-for-service payment, at least initially, but then offer substantial bonuses to the provider organizations, to the ACOs, that are able to improve quality, and then a share of the savings if they're able to reduce costs below where they were projected to be. Well, there have already been a number of pilots that were run by Medicare over the last 5 years. The physician group practice demonstration, which was fundamentally this model with a slightly different benchmarking approach. The Brookings Dartmouth Collaborative that Mark McClellan and I are running, we have 5 pilots around the country that are already embarking on forming these payment arrangements with their private payers. And most of the private payers are involved in trying to work on this as well. And so where are they in the process? Well, one of them, Norton Healthcare and Humana, have signed an ACO contract for their under 65 population. The physicians at Norton are working hard with the hospital to pull themselves together, reorganize care, figure out how to work with Humana to get really useful, timely data that helps them understand how their patients are doing and how to improve their care. So it's actually quite an elegant partnership between the payer and the provider. Instead of dickering over prices, they're trying to work together to say, how can we jointly improve care?
Now, Gail, you have looked at the healthcare system from a variety of angles, and I know you're following this very carefully. How skeptical are you of this? Is this the magic bullet? Will this solve our problem?
I'm a little concerned or dubious, and the reason is precisely because of what I saw happening with the physician group practice demo that Elliott just mentioned. These were 10 setup cases, in the sense that if anybody should be able to produce savings with quality, it ought to have been the 10 groups that came into this demo. And what to me was the most impressive is that while all of them were able to meet the quality goals, in the initial year, only 2 of them were able to produce savings at a level that would allow them to share some savings. And even after 3 years, only 5 of them have been able to do that. I say that's important because if these groups couldn't pull it off, it's hard to see how likely it is for small groups of physicians who are going to be loosely affiliated to be able to organize themselves enough to do this. But maybe, and that in no way should be interpreted to say, I don't want to see this go forward. We've got to get away from where we are, which is a reimbursement system that rewards for more and more complex, that's fragmented, that's stove-typed. And right now, most physicians are in small single specialty practices. So we'll see whether this accountable care organization is enough to induce physicians to change their behavior, to reward the kind of behavior we'd like to see in terms of producing accountable care. My biggest concern right now, my single biggest concern, is the only entities that will step up to the plate are hospitals. Understandable, hospitals are going to be entities receiving the payment. Some of the time they're more organized or better able to do this. My concern is that over the last decade we've seen a large shift in power toward the hospitals as they've merged and consolidated. And if they are the only entities receiving the payment, it will have a bad imbalance between groups of physicians and the hospital. So when I've been out speaking around the country, I am pleading with physician groups to be willing to be the entity receiving money with or without a hospital. Pair up with a payer if you want, but don't only be the recipient in a hospital-led ACO or you will rue the day.
Well, I think Larry's probably the right guy to comment on how high a hurdle that is. You know, Larry, besides doing a lot of great health services research on the kind of systems that improve care, we asked you to come in part because you did spend a couple decades actually leading a primary care practice in California. So you really do have a boots on the ground perspective on what this challenge entails. So can we make these changes?
I think that, first of all, I don't think that accountable care organizations will succeed if they don't make life better for patients and also for physicians. They just won't. I don't think you can have a major delivery system reform in this country with physicians actively opposed to it, and I think we found that out in the 90s. I think that in terms of the barriers, I think performance I see as a function of incentives plus capabilities. So if ACOs are going to become prevalent and do what we'd like them to do, the right incentives have to be in place, and the provider organizations have to have the capabilities to change the way care is provided. And I think that it's going to be very difficult to get both correct. I think it can be done. I hope it will be done. But I think it will be difficult. I wouldn't bet a lot on it, and I don't think it will be quick. But I do share Gail's concern about potential hospital domination. I think one of the most significant and least publicly noted things that's happened in the healthcare system in the last 9 years or so is very rapid increase in hospital employment of physicians. Not just primary care physicians, but specialists, and not just physicians at the end of their career or the beginning of their career, but physicians at all stages of their career. It's changed in the demographics of physician practice very quickly. I mean, hospitals have capital, they have skilled managers whose job is to make things happen. They're not practicing medicine, and so they have a lot of advantages in trying to form ACOs, and ideally the capital could be used to make functional ACOs. But I think we all know that there have been problems in the past, and I could easily talk about problems I would anticipate in the future if we have a system in which we have almost only hospital-dominated ACOs, and most physicians are employed by hospitals.
I'm actually less worried about who's running them than I am about what business model they're operating under. If the business model is generating revenue, I'm not sure it's aligned with what we want to achieve. I believe that the success of this model will depend not on which business model it is. I hope physician groups succeed, I hope hospitals succeed. It will be on whether we have performance measures that make sure they're paying attention to what patients really want, and that will require making physicians' lives happier. If you look at the places where it's starting to work, the initial anecdotes, and certainly here in Massachusetts, where the alternative quality contract strongly emphasizes primary care performance in terms of the kinds of measures they're being held accountable for, you start to see investments in primary care practice.
Larry, for clinicians, not just physicians, but other clinicians as well, who are actually delivering that care? What should it feel like?
So I think in a high-functioning ACO, there'd be a couple of major advantages for physicians. First of all, you wouldn't be making money by churning volume as fast as you could. You could get off that assembly line. Secondly, you would feel, because of the organized processes to improve the care of a population of patients that the ACO is responsible for, you wouldn't go home every night feeling that you know that there's a lot you hadn't done for your patients that you could have done. Third, instead of trying to do all those things yourself, in a well-organized ACO, physicians would actually be able to spend their day doing things that really would be high value for patients, with a lot of help from the rest of the staff and use of various kinds of organized processes to improve quality for the population of patients of the ACO. Not just the people who happen to come into the office, but everybody, and not just during face-to-face visits, but in between visits as well. I think there are many potential advantages for physicians in that. It will require, I think, a major cultural shift in the way physicians think about what's a good physician and what's quality. So quality isn't just what I do for an individual patient while they're in front of me. Quality is what my organization does for our population of patients all the time.